the question about eyes is tropia. So hyper or hypotropia. That's this eyes go these ways. Okay, I was like, I maybe, but I don't know a Clinton Skills 1 question. So I had to go back and answer it for myself. Okay, this is going to be a little weird because we're going to go through like one pathology and then we're going to take a quiz. And we're going to come back, we'll talk about the quiz, and then we'll go on to the last section. Okay, so fingertip amputations, injuries for our population. Oh, come on. Thank you. Okay, we're safe now. We've gotten our warning. Okay, for our populations, this is something that you're going to see a lot. They get slammed in doors, the doors of armored vehicles. They get crushed at the gym. They get smashed in a million different things that our people are doing with their hands. So seeing a lot of crush injuries in my time. Lacerations generally happen to the non-dominant hand, okay, unless they're inflicted by another person. Obviously, a defensive wound would be on their dominant hand. Kind of in that picture to the right, I kind of want to point out that they didn't replant anything. I don't know if they had the spare bits hanging around, they just didn't have them, but we don't always do that. So I'm going to talk about when we do things like replantation, just so that you can kind of keep that in the back of your head as you go and try and find the wayward bits. So because there are a lot of nerves in the hand, that explains kind of what is going on with these adverse outcomes of the disease. So chronic pain, neuromas, or complex regional pain syndrome, that all has to do with the fact that there are so many nerves in the hand, especially in the fingertips, that make things work. And so when we have problems with those nerves, they cause problems. Changes to the nail matrix can result in nail changes. Some decreased range of motion if there's scar tissue across those joints, especially the distal fingers that keep them from moving. Weakness and decreased sensation. So when you are doing your physical exam, these are bloody messes. So control the bleeding, can use tourniquets at the wrist, tourniquets at the forearm, they work. Then you get to do your exploration, figure out what's where, what isn't where, what is mangled but still attached, what isn't still attached, those kind of questions. So one of the things we're looking at is bone that's exposed, meaning that there is no tissue protecting it or even around it to figure out what to do with it. You need to check the viability of the loose tissue, particularly neurovascular status. Some of these injuries you look at and you say, there's no way that flap has anything, but it actually can. So because there are so many nerves, so many redundant systems, it can actually have sensation to flappy bits and also have vascularity to that flappy bit. So you actually need to do like 2-point discrimination on a flap or a part that's hanging off that you normally would say, that's not, we're gonna, okay. Don't feel the need to trim anything. And I'll talk about why here in a minute. And then you kind of need to figure out what was the nail bed. Where was the nail bed in all this mush? Imaging, we're going to get plain films mostly because we need to see where soft tissue and bone structures lie relative to each other to help us figure out where we're going to go from there. So our goals are to get soft tissue coverage that has some kind of protective sensation. We don't want asensate things out at the extent of the body where they can get injured. So we want it to have some kind of protective sensation, and we'd like them to have length if we can give it to them, because that allows them to do things like type and fine motor skills and things like that. Okay, lesser injuries may have this subungual hematoma. So that's what's in this middle picture here. So it's a blister, blood blister underneath the nail. So the blood is trapped underneath the nail. These can be incredibly painful. So if you look at somebody's finger and you're like, yeah, you're blowing that out of proportion, it's actually a lot of pressure for a space that's got a lot of nerves. So to treat that, we're going to drain that by drilling through the nail. You can use cautery, but just know that when the cautery goes through the nail, then it's creating a clot and may not actually let the pressure out. So it works a little bit better if you use something sterile, like a large gauge needle, so that you can create a hole that will actually let things drain once you get through the nail. And you basically just spin it, a little bit of pressure, keep spinning it. The bevel, the shape of the end of the needle, actually acts as a drill as you spin it back and forth. And we'll go through the nail without pushing. And then you can, something's going on at NSA Bethesda, and my phone has been blowing up all morning. Okay, whatever it is, it'll be on the news tonight. Okay. Subungual hematoma, drain, you don't need to put pressure on it. You just use something sterile. That's why this is a needle. And that'll provide a lot of relief for your patient. Okay. If you don't see an exposed bone and you can get the soft tissue closed around that area, then we need to clean it really, 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 really well. So do an irrigation and debridement. You have to be able to suture it with no tension. Okay. Otherwise, you're going to result that your treatment is going to result in contractures, and we don't want to go later and have to do procedures that change that. So make sure that you don't have any tension. If you don't feel like you can get it back together with no tension, then something else needs to be your treatment plan. You can't leave these open. Every time that I've said leave something open today, you guys kind of go, oh gosh, I'm just going to leave it open. The hand is a miraculous organ. It does healing with very little problems on its own, probably because of the importance of our hands. So assuming that it's not a huge gaping wound, leaving it open while they get evacuated or things like that is not a bad plan, as long as you cover it, keep it moist, and away from germs. Wet to dry dressings is kind of how we help wounds to stay wet. So the principle here is that we apply something, gauze, over a wound that maybe is going to get kind of disgusting over its healing process. And as that wet dries, the grossness sticks to that gauze. And then when we peel that off, we take the grossness with it. Okay. These are usually exudated processes. They look kind of smelly. They're actually very clean and doing really great things. They just don't always look awesome. And then we do some soft tissue rest with a splint. So immobilize them so they're not causing flexion and extension across the joint. We'll give them instructions on gentle range of motion and get them hooked up with occupational therapy so that they can start healing this problem and get good function. Unfortunately, if there's bone exposed, you have no choice but to get them to ortho because they've got to do something to change that. And something is as little as sending the orthopedic down there to take a rongeur, which is basically a really fancy set of clippers down there, and clip off all the extra bone, wash it out again, and then close it. And it ends up short, but it's not an OR procedure, it's a bedside emergency department procedure. Tetanus, obviously our dirty environments that we work in, that's a risk. An oral antibiotic is good coverage for this. So here we have kind of what the dorsal and palmar view of this shortened finger would look like. It's got great range of motion. That's awesome, right? And then we've kind of got some x-rays showing what that shortened digit looks like. And that's considered a good outcome. I imagine you know somebody in your family who has a fingertip that they got taken off. My one word of advice about kind of this process is we're very careful about the nail matrix. So I saw a guy at Fort Hood who had had multiple fingers crushed, and one of them, they didn't fully debride all of the nail matrix. And so the nail matrix, which had been enveloped into one of his closures, was still making nail, only it was on the inside now. And so he had a very, very painful, it feels like ingrown toenail, only it's like actually inside growing. So we had to come up with a way to get in there, get that nail matrix back out so it would stop growing that nail in that hole that it was in. So those are kind of some of the consequences of not knowing where the nail matrix is in this scenario. Okay, so when should we refer? So these are very specific. This is probably the most specific we've had any referral decisions red flag slide. Okay, so when are we going to try that replantation? These are those categories. Okay, and it's not always replantation. Sometimes this is transplantation from someplace else. Okay. So younger than 6 years old, they're very plastic. We take advantage of that and we can give them back fingers. If we have a thumb that's at or proximal to the IP joint, thumb is important in grip. If it's too short, it doesn't grip well. So that IP joint, proximal. Fingers distal to the middle of the middle phalanx. So middle of middle. Why does it say distal? Oh, distal to middle of the middle phalanx. Okay, so if it's in the middle phalanx, that's bad. If it's the distal phalanx, we don't care. Or if it's multiple fingers, get them over to ortho so we can start working. Transplantation could be transplantation means taking it from somewhere else. In kids, we take big toes. Sometimes in adults, we take the big toe too. But we can move fingertips around. They do microplastics and get nerves and vessels back attached, and it's pretty cool to prioritize the fingers that they're going to need versus the fingers that they are going to use less. They can take off whole rays. Like if they need the tip of a finger, they might take off the whole pinky ray and use pinky parts to reconstruct stuff. It's pretty cool. Hand surgeons are awesome. Find a good one. Okay. So that is the end of that set of lectures. Thanks. You should have just been louder. Just been like, ah! Last slide. Yep. So if it's the distal phalanx, I don't care. But if it's anything that's at the middle phalanx, yes, we need that. So it should say, if it's proximal, wow. This bullet's weird. Okay, so proximal to the DIP, I care. Yes. I will try and do something above and beyond. Yes. I mean, I care about it, but it's the other one, but I just care less. It's like fibula and clavicles. Okay. So it is almost half past. So I'm going to see you again at 10 till. We're going to go over the quiz, and then we'll launch into the remainder of it. So take your, I know you just had a bio break, but whatever you need to do, take the quiz because that's 12 minutes. How a question would be worded to kind of talk about its uniqueness versus what's the most common. So again, most common are skin bacteria, but the weird one, the catchphrase one, is going to be the multiseta. So other options on there has the ones that are definitely not unique. Alpha hemolytic staph aureus, definitely not unique by any means in the body. So kind of watching some words like that, but pastorellas are a weird animal bite. Okay, which of the following is an immediate pain control measure for patients with subungual hematoma caused by a partial fingertip amputation? So that was what I talked about with drilling through with the large gauge needle. Immediate, so it says immediate. Oral medications are not going to give us immediate pain relief. You're going to have to wait until their body metabolizes it. Keeping the severed portion isn't going to do anything for their pain necessarily. It may help their healing process to have potential, maybe it helps their mindset. Suture the opening closed, that's going to increase pressure. If we can't do it without tension, that could cause contractures and things like that. Disruption of the central band of the finger extensor tendon. Okay, so as we dissect our finger things on the test, we need to know whether it's a flexor problem or an extensor problem. Luckily, we haven't yet started the flexor problems, so we'll do this one as an extensor problem. demonstrated as resting flexion of the IP joint and extension of the DIP. Okay, so I'm going to draw my little finger. So here's my hand. Oh, give me a hand. Hold on, I'm drawing here. Hand. Okay. And then I'm going to make a flexion at the PIP, flexion at my PIP, and extension at my DIP. So here's, ooh. Oh, I get what I'm doing wrong now. I'm pushing that button. MCP. No, just don't push it. PIP. DIP. Okay. So I recommend a tactic like that when you guys are taking the test, so you can see which one it is based on my description. Dupuytren's contracture, MCP, and PIP flexion. So that one is flex, flex. Mallet is going to be DI. So here I gotta. Okay, so this is the kind of analysis that these questions are gonna. PIP. Oh, that's wrong. That's good. Okay, I'm going to start all over again because that's what it's going to take. Okay, mallet. So this is DIP flex. Dupuytren's is going to be I didn't push it that time. MCP flex. PIP flex. Okay, so this kind of technique to be able to kind of see where we're going with each of these finger deformities. Jersey finger is a type of mallet finger. And then a swan neck is going to be our exact opposite of what I just drew here on the right. And I'll go over that here in a minute. Okay, so correct was boutonniere. I have to do lots of erasing though. Which of the following fingers is most commonly affected in Dupuytren's contracture? Ring. Remember, indexes are most protected against this one. So it's the least of them. So it's ring, little, and then middle, thumb, index. Is regurgitation in my brain. Okay. Which of the following is the most common causative organism in an infection of the pulp of the finger? Skin bacteria. Good job. Okay, so Pasteurella multicida, again, goes with our animal bites. And then Staph aureus is more common than the strep's. Which of the following is the complication of untreated felons and paronychia that requires surgical intervention? So either of them can result in infection of the underlying bone, and that requires surgery. Stiffness doesn't require surgery necessarily. If they had a rupture because of it, if they were tied together, then that could be something. Secondary osteoarthritis is an effect, something that happens, but it doesn't require surgical intervention. Osteonecrosis usually has to do with a lack of blood supply rather than an infection. And osteonecrotic things, like we leave osteonecrosis of the hip. It's not awesome, but we don't necessarily do anything about it. So just remember that we're talking about requires surgical intervention. Things like the hip, that'll come. We'll get over to that next block. You'll start to understand that osteonecrosis is not always something we have to go in and ferret out. Which of the following physical exam tests is described as placing the backs of the hands together and bringing the elbows down to hyperflex the wrist to compress the median nerve? So bring your body to the test, okay? Put your backs of your hands together, bring your elbows down and say, ooh, which one's this? Okay, that one's Phelan's. Finkelstein's is ulnar deviation of the wrist with the thumb wrapped inside the hand. Job's resisted abduction, the arms in that supraspinatus. Tunnel's tap is anywhere you tap where a nerve is. And Ruth's test is the elevated arm stress test, where we were doing this and talking for a long time. Which of the following compartments of the dorsal wrist is implicated in de Quervain's tendinopathitis? Question left over from before. So this is first dorsal compartment. Good job for those of you who got that. In terms of how they number them, they're from the thumb side over to the pinky side, 1 through 5, and it has to do with which of the extensor tendons are in there. We didn't talk about it, so that doesn't make good test fodder for next Friday. I appreciate the one person who said, didn't get that. Okay. Which of the following nerve distribution best depicts carpal tunnel syndrome? So there are a bunch of pictures there. So it has a bunch of nerve distributions. So we want the one that has the palm, that it has the thumb, index, and long picture. The other ones would be like the pinky and the ring finger, and then the other one should be the dorsal side of the hand. Okay, which carpal bone is the one with the pink circle? So a circle of unknown color if you're colorblind. So that is the lunate. Good job. Okay, in terms of the others, this is scaphoid here. This is capitate. The thumbs are the traps. And then we've got hamate and pisiform and triquetrum on those three. They're overlapped. Okay. Switching topics. Remember, I can't swipe on it's in PowerPoint mode. Okay. Flexor tendon injuries. As you prepare for the test, I want you to spend some time kind of working through this image and contingency planning what you would and would not be able to move if you lacerated it in various positions along this course. So pretty much anything to bone that occurs this way, I would be able to probably move my MCP, right? Because it's not run by anything that's this proximal, this distal, I'm sorry. But my motion here and my motion here would be impacted because I have no pulley to pull on them, no string to make them work. Because the string has been, both strings have been cut. Whereas maybe a superficial injury, here, I would just, let me see if I can make that a different color because that would be helpful, right? Color, purple. That wasn't helpful, Robin. Try again. Okay. Didn't push that button that time. Okay. Whereas something at this level would only affect your ability to move your DIP. Something, well, hold on, gotta do different colors again. Something more superficial, still in purple. Okay, maybe we don't get to do any colors. Okay, what am I doing wrong? Pen, switch it. Or maybe it's that color because, okay, now let's try. Okay, so something more superficial would only affect the PIP joint. So that kind of analysis on what moves where. Okay, FDS, flexor digitoris subliminal, and the superficialis, yeah. You're right, superficialis, thank you. I appreciate the correction. and profundus is the deep one. Okay, flexor digitorum profundus, meaning deep thoughts. So that's what the FDS and FDP. Who has a subliminal? Probably the mini, because I'm remembering it that way. Okay, superficialis profundus for FDS. Both of them are flexor digitorum, flexing a digit. Okay, so what can happen to these tendons? They can be ruptured, they can avulse, they can fracture of the bone, or we can sustain a laceration. Jersey finger, that's an FDP avulsion. So where the FDP inserts on the distal phalanx, it avulses, pulls off with a chunk of bone. Ring finger is the most common in terms of injury, only because it's pathetic and sad and it's not as strong as its mighty middle finger or important as the little finger. I don't know why. Ring finger. Clinical symptoms, they should have some kind of history of trauma that would fit their scenario, and they're going to have limited active range of motion. So when we isolate and test each of those, both profundus and superficialis, then we are going to find that they have an inability to actively range. The level of interruption, again, directly plays a part into what they can and cannot move. If we don't treat this, then we are going to result in they're not going to have that range of motion to that part of their body. So we should do something about it. May have weakness if we get a partial healing. Okay. So we're going to test active finger range of motion and strength at each of the finger levels by isolating them. Let's see here. How long can I borrow your hand? Okay. So we're going to flip it over. Okay. So you're going to use, and I'm going to say, okay, can you move your thumb at the joint? Can you move it? Yeah, okay, so, and then we do, keep going. Go ahead and move your thumb all the way over. Good job. Okay, on your index finger, can you move the end? Okay, how about the middle? Okay, how about the whole thing? Okay, like that, all fingers. And then you're going to do the same thing with strength. It's just a little harder because I can't be the table in this scenario. So I'm going to isolate this, and then, okay, she's got full strength. Same thing. Move the whole thing. There you go. Okay. Now, same thing over here. Just curl my finger. Okay, good. Curl. There you go. I know her finger. She's like, which one? Which? Okay. So we test strength at each phalanx. You put your finger over the phalanx level, and you test strength on each and every joint so that you can understand what's normal and what's weak. Neurovascular with 2-point discrimination. I've said that a lot. Don't worry, there's a tool for that. So it looks kind of like a star. You can do it with a paper clip, which might have been how you guys were taught. Or you bend a paper clip and you put the two ends of the paper clip. You have to measure them though. There's actually a tool that the hand surgeon runs around with. It looks like a star. But each of the sides of the star has 2 millimeters, 3 millimeters, 4 millimeters, 5 millimeters, and then they close their eyes and you say 1 point or 2, 1 point or 2, and then when they start to be able to say 2, then you check blindly again, and then you say, okay, the point where they started feeling 2 instead of 1 is blank millimeters. Okay, 2-point discrimination. So, story about this picture. My husband thinks it's hilarious that when my children injure their middle finger that he sends me a picture with them flipping me off. Hilarious. Every single time. Every time he goes to my in-laws' house, I get a picture of my kids with tears flipping me off. And I'm like, seriously, man, it stopped being funny like 2 decades ago. Why there's a middle finger injury here is because every time I see it, it amuses me. Okay, so this person has a laceration. It's actually a pretty good picture, right? You can see the resting tension of the flexor tendons. Like these, this is obviously pre-op, like he's got the blue towel. Hands all clean. It's laying there. That finger's resting, and yet it's not bending at all. Okay. So probably a rather deep wound right there that's got both FDP and FDS lacerated. That's got it so that it's resting in that position while the other fingers are kind of curled in that position. Resting hand. Okay. So we should get x-rays just so we can look for avulsions, especially if it's not a laceration scenario, but it's more like a jersey scenario where my finger got caught on such and such. We really want to check. And our judgments on what to do with it are based on how much of the surface of that bone is involved. So with this particular one, so right here is where the extensor tendon attaches. Can you appreciate how this portion is really not in a congruity with the joint? Sure. It's actually being pulled dorsally because there's not enough of the part on the palmar side to pull, counter pull. In addition, this got all spun around, so I recommend a hand surgeon to go unspin that and put it all back together. But the real big issue is that this joint, if they keep this joint, it's not going to end up well because they're going to use this and they're going to develop arthritis that's going to affect that finger. So it has to do with how much of the joint surface is involved. Okay. So what should we do about it? We want to splint with the ends of the tendon together. Okay. So we call this an intrinsic plus position, but how much, who's intrinsically is really, okay. That's where we get that. Remember when you did first aid and you learned to splint in the Coke can position? Okay, that this is kind of where we were going with that. We want those fingers flexed so we can get those ends of the tendon as close together as we can. If it's really far proximal, you can actually like bend them really far down and splint them like that so they get the tendons as close together as possible. So not the blade that we talked about yesterday. Operative repair. If the flexor tendon really is injured, it needs a surgeon. Let the surgeon be the one who says it doesn't need surgery. Okay. So anything in this category goes to a surgeon. Your job is to put it in that resting splinted position while they're getting there. Okay. Adverse outcomes of the disease have to do with stiffness. Immobilization of the fingers and hand result in stiffness if you keep them there for a long period of time. So to reiterate, referral decision and red flags. All ruptures, lacerations go to orthopedics. When you call orthopedics to give them a laceration handoff, you would be awesome if you use the zone. They're going to go, ooh, that PA is really top notch. Okay, so I'm going to go over it. Again, this is style points, not necessarily anything else. You'll notice that some of these zones correspond with our amputation zones that we talked about a little while ago. Okay? The only one that's not marked is the zone 1 on the thumb. So zone 1 is that middle phalanx, distal end of the middle phalanx, distally. The attachment that moves the distal phalanx. Zone 2 is that distal palmar crease to that zone. Zone 3 is kind of from the web space of the thumb, just straight across. Zone 4, it's like the hand, the edge of the hand. Anything proximal to that is zone 5. Unfortunately, the prognosis, as the number gets higher, the prognosis gets worse. So if you have a zone 5 flexor tendon injury, we call that spaghetti wrist because what happens when you look inside the wrist is all 8 of those tendons look like a bowl of spaghetti. They're all twisted up. And then you get to play the game of pull on that, see where you want it to go, pull on that, see where you want it to go. And they literally have to figure out which of those 8 wires goes to which of those 8 other parts, and they have to reconstruct them. It's interesting, but incredibly laborious hand surgery. we're going to take those same flexor tendons and we're going to make them get infected. I'm sorry, that's just where we wanted to go from there. Okay, so flexor tendon sheath infections. You have probably heard this as flexor tenosynovitis. The tendon sheath extends, it's these kind of tubey looking things here. Okay, so obviously flexor tenosynovitis in the small finger is a big problem. It goes straight down to your wrist. Thumb, yeah, that's pretty proximal too. Fingers, okay, I can appreciate that. Okay, extends from the DIP to the metacarpophalangeal joint. That's going to show us kind of where we're going to get swollen when we get this infection. Please note that these are on the flexor side of the hand. Okay, I once got called to the emergency department to rule out extensor tenosynovitis. Well, the extensor tendon doesn't have a sheath, therefore you can't get extensor tenosynovitis. You can injure your extensor tendon, but you can't get a tenosynovitis to it. You can inflame it, you can get a tendinosis, but you can't, it doesn't have a cyno to get irritated. Did I cover everything? Yes, okay. So 24 to 48 hours after some kind of seeding event, like a puncture, gardening, some kind of fall, something that introduces bacteria into the flexor tendon sheath, they're going to get severe pain. It should be on the flexor side. Okay. If they have puncture on the extensor side, my concern for this goes way down. Unfortunately, this is limb threatening. So insert, if I see this in a service member in a foreign environment, I should call for my medical friends to come and pick this person up and get them out of my AO. Okay, Knabel signs. This should be your second time through this, right? You should have gotten, oh, I'm getting no's. Pathology didn't cover this? Excellent, I love this opportunity. Okay, Knabel signs. It's an eponym. I'm sorry. We'll come up with a better term someday. Okay, so there are 4 of them. Okay, the first is sausage digit. Okay, when you look at the finger, you say, that looks like a hot dog. Okay, yes, I realize hot dog is not, other cultures use sausage a little more than we do, but you should think, ew, that looks like a hot dog. Okay, pain to percussion or palpation of the tendon sheath. So in that area, from the DIP to the MCP, if you do a tap over that, they are going to want to get you away from them. They're going to move you. Okay, it's uncomfortable. They don't like it. They'll move your hand. They'll move you. When they're in the resting position, they want that tendon to be resting. So their finger will be in a rested position when you come into the room. And if you take it from that position and you try and extend it, they will again take their hand from your hand. They'll move your hand away. They'll make you stop. Okay, Knabel signs. The next question students usually ask me is, how many do I need to define this? Aside from sausage digit, they're pretty specific. Fingers, when they get swollen, they look like sausages. So don't get wrapped around the axle on that particular one. But if you have that plus these others, that's pretty specific. It has to do with what you're examining, right? Okay. So there's not really you have 3 of them. It's not the Centaur criteria. You have 3 of them and you get your diagnosis. If you have, especially the sausage digit plus one of the others, that you're probably there. Okay, we're getting plain films just to double check what's going on. We're going to see swelling without any bony abnormality. Maybe there might be some air. We have an air-forming bacteria that's causing our problem, or they had air introduced during their trauma. Doesn't happen in every case. Maybe a foreign body if, I don't know, their flexor tendon injury, sheath injury was caused by an animal bite or a gardening thing. Maybe they got some kind of thorn or something stuck in there. You can see it. I don't know, you're looking for it just to make sure it's not there. So what do we do about it? Well, we jump straight to IV antibiotics. Okay, I'm jumping to that, and I'm starting with generic coverage that covers for skin bacteria, staph and strep, until I have the opportunity to make changes. Okay, as a primary care physician in the continental United States, you do not have admitting privileges, so you have called orthopedics at this point. Okay, so just to get IV antibiotics, somebody had to call to take that patient and make them inpatient for their IV antibiotics. Kind of goes with this. This isn't your call, but this is a high priority. So you are setting them up for a washout. So you make sure that you get them to ortho. If ortho holds on it, that's their call, not your call. But it needs to be given an opportunity. So that goes with our evacuation kind of thing too. If we don't effectively treat this, fibrosis and stuff can happen in the finger, not to mention limb threatening, which will result in finger stiffness. So we kind of need to do this. So the washouts for these are actually kind of cool. They can do them open, obviously, everything can be done open. But they can actually do micro procedures now, where they just open the end of the flexor tendon sheath right at the DIP, and one right at the incision at the MCP, and they basically just flush it. They just run lots and lots and lots and lots and lots and lots of fluid through that tiny little hole until it starts coming out clearer and the patient starts to improve. It doesn't have to be a huge, open grotesqueness. Oh, human bites, also known as fight bites. Okay, same thing here as when we talked about the animal bites. Okay, our most common are still skin bacteria, but the freaky weird one on this one is Eikenella corrodens. So it would be the unique bacteria or special bacteria that is associated with human bites. Okay, so they can be caused by small children with really strong mouths, okay? So they don't always look like this, but fight bite is far more common, especially in our populations. So we're going to talk about that one. Okay, this is caused when I take my closed fist and I put it into somebody's face to make them stop doing whatever it is that I think they need to stop doing. Okay. When your finger is in this flexed position and it sustains a wound, that's what's in this top picture. Okay, so the dashed line right here, that's a terrible color now. Let's go back to red. There we go. Okay, so that dashed line right there showing the line of injury when the hand is in this position. The reason this picture is here is because when they extend their finger, the extensor tendon gets pulled proximally, meaning that their hand, now that they've laid it on the exam table, they've hidden their extensor tendon wound from you. So when you're opening their hand and you're cleaning it out, you can't see the extensor tendon injury because they've hidden it proximally. And you may miss it completely because you're focused on the wound that is right in front of your face and they've hidden their extensor tendon. So green is their extensor tendon. So you're going to see this capsule injury. It's going to correspond with a skin injury, and you're like, okay, I have cleaned the wound. Problem is that me and this podium, we're not friends today. You're going to miss the extensor tendon injury, which has moved proximally as they extended their fingers. My next screen touch will be a right click. That's helpful to know. Maybe that's why I keep messing up. Okay. So clinical symptoms, they're going to have some history that's going to tell me that they got their finger exposed to someone's mouth. They may have shaken it off and said, it's no big deal, I'm going to go home, and come in days later with an infection. If their extensor tendon is completely disrupted, then they'll have what we call an extension lag, and that just means they have an inability to actively extend their finger. Okay. So the lag is, I can't make it do the thing, so they'll be able to pick up the other fingers, but that particular finger won't extend when they fire those muscles. Adverse outcomes of the disease: if I ignore partial tendon rupture, they can get a complete tendon rupture, abscesses from gross mouth bacteria, osteomyelitis, because it's a seeding event. Same thing with septic arthritis if the joint capsule is violated. And then septic tendinosynovitis. Again, they'd have to go kind of crazy so that this infection wrapped all the way around their finger and then went into their tendon sheath. Okay, so just by its position on this list is where I feel it is in likelihood. So on physical exam, I need to locate the lacerations both in the skin and at the tendon, remembering that that tendon has snaked proximally when they put their hand nice and on the table. It might be easier to get them to put back into that fist position, find things, and then treat them. We want to, again, isolate each of the extensors and measure those. So very similar to how I did the flexors, only this time I'm going to do each of the individual extensors. The two on the extensors on the small and ring fingers, they are wired together, so judge the other hand as what normal is, because sometimes they're just dumb because they're counter-wired together. And then we need to rule out any kind of ascending infection to the body. I'm going to go ahead and get my plain films just so I can look for a fracture or foreign body. Convince myself it's not there. It's got some pretty good soft tissue. Podium, come on. This is not a fun game. Okay, so that's some pretty good soft tissue swelling, but I don't see anything else on there. If there is pasta culture, you should do so. We're also going to start getting some serum labs that are going to help us judge whether this patient is improving or getting worse. So serum white blood cell count, and then our inflammatory markers, erythrocyte sedimentation rate, and C-reactive protein. Treatment. So non-operative, so I'm going to give them a block. Tends to be like a wrist block. Irrigate and debride, figure out what's where, figure out how much is disrupted, figure out what parts of this tendon are and are not in continuity. If they have something going on, please don't feel the need to suture it closed to trap those bacteria. You can dress and give them oral antibiotics. And we're going to do serial rechecks on this to make sure that they don't get an infection or tear the remainder of their extensor tendon. Yesterday we talked about the little cap that goes on the bottle that makes irrigation easier. This is another tool that they have in the emergency department. It's a water gun. So you drop the tails into the is it sterile water or normal saline or whatever they hand you, and it has a battery pack and it's a water gun. So you put the edge up to the wound and turn it on, and it goes and it's squirting water. Okay. So fun tools that you can use. Not as cheap or as much fun as the caps though, so it's okay. Operative. Indications for that are if there's an infection, mostly so we can go in and do some surgical debridement, and they'll get IV antibiotics to go with that as well. And then if you have a complete extensor tendon, that may not be an operative indication, but you should probably let ortho, again, decide whether that's something they're willing to take. It does appear that this person, first of all, that's a lot of debridement right there. Something's going on kind of right in here. I don't know if they put it back together or what, but it's just, the tendon is supposed to be this pearly white color. that one looks kind of all beat up. Adverse outcomes of treatment, infection, amputation, that infection spreads, and if they have an antibiotic allergy, they would have an adverse effect. So who needs to get shipped off to ortho? If they have an infection, if the joint capsule is involved and we're worried about septic arthritis, or if their tendon is ruptured. Steinbach's disease. So this is osteonecrosis of the lunate. Okay, so osteonecrosis is caused by altered blood supply to bones. The scaphoid likes to do this. You probably heard about that at some point. This is a different disease process. Once the lunate gets a disrupted blood supply, that results in bone collapse because there's not enough structure there to hold everything out. And eventually this abnormal shape will result in arthritis. So this is supposed to be a smooth surface that articulates with the ulna. And you can see it's like all deformed and doesn't look like it would glide smoothly with its relation. Who gets this? Men 20 to 40 years old. So they should have some history of trauma, although it may be remote and it may be minor. So don't brush it aside. Keep this in your differential until you've run this one aground. Their pain is going to be dorsal, which is pretty unique. Lunate is really the one thing that loves to do dorsal wrist pain. So there's kind of, you can feel all your extensor tendons coming out. There's a little hollow just next to that. They're going to get pain in that hollow on the radial side of your extensor tendons. And kind of already talked about secondary osteoarthritis due to that abnormal shape. So you can stick your finger on the lunate and they'll have tenderness to the lunate. You just got to stick your thumb in there. So dorsal mid-wrist is where you find that nice yellow circle there. And when they engage all the stuff that's around it, the stabilization ligaments between each of the bones, they're going to be weaker because their wrist is basically shifting when they try and do grip activities. So they'll have a decreased strength even if it's their dominant hand. How we know that this is what's going on out of that rather ambiguous story that I've led you here on is we're going to get some plain films. And if it's early, we're going to see a focal increase in density, also known as sclerosis, of the lunate. If it's later in the course, you're going to see complete wrist collapse, and it looks very ugly. So finding that sclerosis on radiograph is comparing how white that lunate is compared to like the density of the capitate. Also, we haven't discussed scaphoid fractures yet. So that's not what I'm showing you a picture of. Okay, so eyes should go to the lunate. If it's extra white compared to its neighbors, that is sclerosis of the lunate. Wrist collapse. This wrist has started to collapse, but the ligaments that attach these bones here will all start to degrade, and then like the wrist will not have the nice rows of the carpals. When you get your MRI, you're going to see our necrotic lunate. A couple of you guys did this as your wrist pathology, self-selected wrist pathology. In this particular weight of MRI, bone is this white color with gray dots. Black is bad. It's like it wanted to tell you it's dead. I'm dead. Okay, it is dead. Dead, dead, dead. So I am going to get this person in a wrist splint. A cock-up wrist splint is fine. They just need to wear it. Take it off to shower. They just shouldn't be going like this while they're doing it. Manage secondary osteoarthritis is really how I, as primary care person, am going to help this person. Is I'm going to set their expectations and help them deal with the consequences. Secondary osteoarthritis will happen. We just need to help them with it. Therefore, all abnormal lunate should head to an orthopedist to help manage complications that come with this. Lunate. Mallet finger. Okay. Mallet finger extensor tendon at the DIP. It's not the same as jersey finger, which is a flexor problem. Boutonniere is at the middle phalanx or proximal phalanx. Proximal interphalangeal joint. That's the attachment. Okay. And again, they're going to get that extensor leg. So again, that means that it's here. And when I tell them, please extend the end of your finger, they go. And it won't go. But when they do it to their other fingers, they can do it. And it may result in permanent cosmetic deformity, meaning that it's stuck like that. Okay, why mallet? If you have taken apart your piano, you know why. Okay, so the thing that when you plunk on you push the key, there's a part that goes dink, 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 dink on a string. The part that goes dink, dink, dink on the string is called the mallet, and it looks like that deformity. So it's got a stick and then a drop down. Okay. Piano, mallet. You learned about the guts of a piano today. Okay, so this is where that whole draw out what goes where parts come into play. So an adverse outcome of this disease, this is an outcome, is a swan neck deformity. It's the exact opposite of boutonniere. So you take the mallet finger, which is here on the right, and then we have some weird compensation things that are going on, and they get hyperextension at that PIP joint. Generally speaking, they start looking like the picture on the right, though. Okay, that mallet. And they have no active extension when I isolate that distal phalanx. Okay, I'm going to go ahead and get my x-rays so that I can look for an avulsion fracture and make a determination, is this a soft tissue problem or is this a bony problem? And here on the left we have a normal x-ray, and then here we have an avulsion. Same kind of rationale when we get this is if that chunk that is avulsed off is big enough, then the flexor tendon starts to win and it starts to pull that distal phalanx towards the palm. That will result in abnormal mechanical forces at that joint and will accelerate osteoarthritis. So what do we need to do with this? This one is going to be continuous splinting for 6 weeks. Thereafter, we'll do high threat splinting, but they'll be with an occupational therapist at that point. We can treat their pain, do all of that. So this, yesterday when we were talking about weird finger splints, this is one where I recommend you just go take a box, military reappropriation, and have it with you at your care site so that you can give these. I usually give 2 because 2 is 1 and 1 is none. It doesn't actually apply here. But when they get wet, you really don't want your patient putting a wet one back on. You would rather them let it dry out, so they need a second one. Okay. And when I say continuous, I actually mean continuous. So if at any point in time they let the finger droop back down because they're in the shower, or they take it off because it's wet, or they just don't want it anymore and it goes back into this position, you have negated every healing that you have done until that point, and they are most likely screwed. Okay, so how do I teach them? Okay, I teach them to do it with a table or something. Okay, so they put their funny little finger down, and they have to use either help or another finger to keep it up to get the splint on and off. But at all times, it must be in that extended position. Again, the second we let it drift down, we've pulled all those healing fibers apart and we've lost the battle. We also need to, they're going to have to change it because it's going to get wet. And if they keep it on, they're going to get gross, nasty fingers. So they got to change it. We get that. While they're doing that, they also need to look at their finger and see how it's doing in terms of infection. If you guys take your finger right now and pull it up by your fingernail, you notice how just proximal to your nail bed your finger blanches? Yeah, if you leave your finger like that, that's like getting no blood. And it will actually die. Okay, so they'll get skin breakdown at the proximal nail, and like that avascular nature will cause nail deformities, can cause an infection. It's like paronychia gone wild. And we just need to teach them, you know, if that starts to happen, let us know so we can adjust your splint or whatever we need to do. So who needs to go see orthopedics? If they have any kind of subluxation, shifting of that distal phalanx relative to the middle phalanx on x-ray, or an avulsion that's greater than 1/3 of the surface. Again, that's so we can stabilize that joint, keep it from shifting. Give me just 1 second here. Okay, we'll make it. I promise nothing for tomorrow. I just wanted to see where we're at for slides so that I know how fast to talk. Sure, we'll go with that as an excuse. Okay, so nail bed injuries. I've kind of touched on many of these up until this point, but here is a cutout of looking at kind of the relationship between the bones and the nail matrix. And given the size of this picture, I kind of want you to appreciate this space right here. So this picture's blown up, right, a lot, and still, you would say the bottom of that to the top of the periosteum of the bone, it's less than 1 centimeter here in this giant blown up picture, which is probably several hundred times my normal finger. So in a human, this is millimeter. So if we have things that affect the fingernail matrix, the bone is just right there. So if the germinal matrix, which is this part right here, has something happen to it, crush, laceration, anything like that, that's where the nail grows from. So if we damage that, it will result in weird nail deformities. So if they come in with a crush or some kind of injury to the tip of their finger, I'm going to get my x-rays because I'm ruling out fracture. My word of advice is, if they smash their finger in the gym and their nail avulsed, I don't care where it is at this point, whether it's hanging off by a thread or what, and they have a fracture, they're called tuft fractures. That's what the radiologist is going to say. That is an open fracture. You will treat it as such. There is a weird one that happens in kids where they actually get a physeal injury in this area because the nail matrix actually slides down into the physis. It's another eponymed fracture. If you have a pediatric person with this kind of injury, they're all going to orthopedics anyway, okay? But if you have a pediatric with a nail avulsion, you need to assume that that's open as well. And just assume it's a Salter Harris instead. Okay, so we talked about subungual hematomas and drilling through with that large gauge needle. Same applies here. If there is a nail bed laceration, first of all, you should block. Probably not the first person if you're, not the first person to see them. You should do irrigation debridement, look things around, explore it, figure out what's where. You can do some absorbable sutures, particularly if the nail is in where it's supposed to be. Okay, so if they still have a nail, even wherever, hopefully it was on them and not they picked it up off the gym floor, but whatever, wash it off, it's cool. You should stick it back in the hole, and you should use some absorbable sutures to hold that open, because we're holding the matrix open so that the matrix can heal normally and it doesn't stick to itself because there's no nail in there. Dress it and splint it. Okay. If the nail is avulsed, occasionally the matrix comes out and it's waving in the wind because their nail isn't there. You should probably stick that back down underneath. Again, my poor patient who had the crush injuries to his finger, you should put it kind of back where it is so that we could identify it. And then you should hold it open with something that's, again, sutured with absorbable sutures. So in the past, I have used the like petrolated gauze, comes in a foil wrapper, and I do my crafting thing, and I make a little nail out of that aluminum foil, and I stick it back under the matrix and suture it in. Anybody else use anything more interesting than that? Oh gosh, nobody's used anything cool? Okay, there's a whole bunch of stuff hanging around. You can use a piece of like whatever dressing, like a sterile dressing that you have various types of. You just want to hold that so the matrix, when it's trying to heal, the matrix isn't sticking to the underside of the distal fold. And suture that in place so that the sutures will absorb and let go as the nail grows. And eventually they'll be fine. Just like when you lose your toenail from running or something similar, like that's the same process that's going on. Adverse outcomes of the disease are matrix injury that causes a nail deformity. Okay, so who needs orthopedics? Open fractures and that physeal injury. So that picture is the one on the right there. That is some kind of nail injury that they didn't catch right away. The nail, like I said, the matrix slid down into the physis and is now trying to grow nail in the physis. Sounds bad, right? Okay, last one. Trigger finger. Okay, at the palm of your hand, so shortest distance between 2 points is a straight line, right? So if my finger mover, its origin is down here, and it's going to right here, then why do I not have little spindles that stick out from my tendon? Okay. That's because of your pulleys. So there are annular pulleys, which is what the A stands for, and there are cruciate pulleys. They are those white fibrous things that hold the tendon to the bone and give it like a thing to slide around through. But it keeps all that stuff tethered and up towards your hand so there's no bowstringing. So they are numbered 1 through 5, so 1's here at the palm. So this is a thickening of the A1 pulley, annular 1 pulley, which is just distal to your distal palmar crease. Most commonly happens in your ring and long fingers. Poor ring and long fingers. Things that can worsen this chances of a patient developing this: rheumatoid arthritis, diabetes, hypothyroid. Doesn't mean it's the only patients that it happens in, but those patients are more likely. What they're going to complain about is locking or catching with flexion of their fingers. Gosh, why is that with me? Okay, I'm going to share it because it came out of your brain. And then you're going to note a nodule at the distal palmar crease. Okay. So remember when I said that I'm going to use code words to tell you which one I'm talking about? Okay, if it's a cord, I'm talking about Dupuytren's contracture. If I say a nodule at the distal palmar crease, then I'm talking about this, trigger finger. Okay, so you're going to put your finger at this A1 pulley, and you have them move their finger. Some of you may be able to find some in your own hand as you do this. Okay, my ring finger on my left hand feels like I have one. Okay, they're not always symptomatic, right? I'm good, but I can still feel it moving around in there. Unfortunately, if I choose not to move my finger because of this nodule that's going in and out of the tunnel, then it could result in a contracture. Hoping I have. Okay. So again, when you do the put your finger in that spot, you can feel the nodule going in and out. Okay, so what is it? It is a part of the tendon that, because of inflammation or injury, has grown fat. But the tunnel didn't grow fat with it. Okay, so every time it tries to go into the tunnel, it'll go through the tunnel because you force it to, but then it can't back up because the tunnel is still there. Or if you get it to the other side of the tunnel and want it to get into the tunnel, it stops. You can force it in and out of the tunnel by forcing the finger to flex and extend, but it just won't go through the tunnel. Okay, so you should be able to palpate a moving nodule kind of at that distal palmar crease right over the metacarpal phalangeal joint on the palmar side. And then you may be able to appreciate clicking or catching. I had one patient who, like, this was their party trick, and it was like Mr. Roboto, dink, dunk, dink, dunk. And I was like, you can stop doing that at any point in time. That's right. We can start with our initial treatments, do some splinting, calm that tendon down, let it rest. Position of function is fine. Night splinting works better still, just because they're not messing with their hand, trying to move it around. Anti-inflammatories, occupational therapy, protection. We can also do some injections, which is what's in that top picture. They found their position with the needle and then they took the syringe off. Non-operative management is reserved for operative management is reserved for those that are non-operative management failures, and that's what we have here in this position. They've isolated that flexor tendon, they're following it to that A1 pulley position, and they do that same seatbelt cutter thing. They use their really tiny seatbelt cutter and they slide it in there and they just cut the A1 pulley. It's not a very large hole, and then there is no tunnel. There's just a tendon that's fat, and it can do whatever it wants. Occasionally the wall, the tunnel ceiling will come back in, but it's usually a lot wider open just because they're going to keep moving their finger with occupational therapy. So the tunnel will now better match their fat tendon. Bad things can happen though still from treatment, tendon rupture, nerve injury, infection, post-operative type things. So who needs to go see orthopedics for a trigger finger if they have already started restricting their range of motion to the point where they've developed a contracture, or if they have comorbid rheumatoid arthritis? That is because the tendons in a patient with rheumatoid arthritis are already very friable, and we're going to worry then that they're going to push to that flexor tendon rupture, and then we'll be in that flexor tendon injury section we saw above. Okay, so I don't have enough time technically to let you do your quiz, but we knew we were going to be pushing it to do it anyway. So do your quiz.